A very good morning, everybody. So today's lecture is on prenatal and postnatal growth of maxilla. And towards the end of the lecture, you will be able to know the various terminologies of growth, the clinical application in relation to functional appliances, methods of bone growth, pre and postnatal growth of maxilla. So we'll start with the first voyage, that means the step where the sperm and the ova fuse and there is growth of various structures taking place in utero. So this is a picture of what looks like at 4th week of intrauterine life. You have the formation of branchial arches. So as you can see, each of the branchial arch will consist of its own nerve, cartilage and artery. And it is basically the first branchial arch or the mandibular arch which leads to the formation of face. So if you look at a baby, this is the typical position with head bent. This is the side view of the baby in the womb. So if you see, this is your frontonasal process carrying the brain, and this is your pericardium and your future heart. This is your neck region where you see the formation of branchial arches. This is going to be your future stomodium or the oral cavity. And here you have your arches, first, second, third and fourth. The first one is your mandibular arch, which gets split into two, maxillary process and mandibular process, which is primarily responsible for formation of your midface and lower face. And this, your frontonasal process, will contribute to formation of your upper face. So if you look at the prenatal embryology of the human face, the above part is being formed by frontonasal process, the middle face by maxillary, and the mandible and the lower face by mandibular process. Both your maxillary process and mandibular process are a part of your first branchial arch or mandibular arch. So we have a look at the 4th week again. So this is the same side view of the baby, the frontonasal process, the developing stomodium, the pericardium, the future brain, and here you have your alimentary canal. And this is your developing stomodium. Now we turn the baby's face towards ourselves. So that's the frontal section. So at the stomodium, you see from both the sides you have the first branchial arch or the mandibular arch coming close to each other. This is the condition in 4.5 weeks. Following which, at the end of the 4th week, you will see the formation of lens placard and the nasal placard, thickenings of the mesenchymal tissue, which will be prominent in the frontonasal process. Okay, and there will be fusion of your mandibular process. Following which, in the 5th week, you see there is budding of the maxillary process out of your fused mandibular process, a typical depression being formed in your nasal placard. Okay, thus dividing your nasal placard into medial nasal process and lateral nasal process. And if you see your lens placard, it has turned into the eyes, which are lateral in position at this point of time. So as we proceed, you see fusion of various processes happening. The maxillary processes are also growing towards each other. You see a depression being formed between a medial and lateral nasal process. Thus, it is leading to the formation of your future nose. Okay, and look at the lateral position of the eye. As we progress, you see something which looks like a human face now, which has contributed to fusion of various processes at different ends. Thus, we know that if there is malfusion of any of the processes taking place, there is going to be a cleft of that region happening. So, restricting ourselves to maxilla for this lecture, we are going to talk about development of palate. So we have two palates, primary palate, which will form first, followed by secondary palate, which will be formed later. So this is the picture again. So these are your medial nasal processes which are going to fuse with each other. If you look at the ventral view, this is your nasal cavity, your nostrils, Okay, this is your maxillary process. These are your palatal shells, and you have your medial nasal process which come and fuse with each other. Along with that, the maxillary processes will also fuse. That means a intermaxillary segment. So this entire fusion together will give rise to our primary palate. Okay. Thus, you have your intermaxillary segment converting into your primary palate, which is actually the part of the palate in front which fuses first, and it is the part which bears your central and lateral incisor, whereas it is the posterior segment which is forming your secondary palate. But the question is, how will your maxillary process or the palatal shells in the posterior end fuse? So this is a cut section of the baby's face. We cut it and this is what we see. So this is your nasal septum. Your tongue is lying vertically in between of the two palatal shells which actually wish to come close together and fuse. But they are being prevented because of the vertical position of the tongue in between. Hence, even if your maxillary processes grow, they grow vertically down. They are unable to grow horizontally and fuse with each other. It's only at the 7th week of intrauterine life that, due to certain changes in the mitotic activity of the epithelium, the increased connective tissue, vasculature, and probably the change of head position of the fetus and various other reasons, that the tongue actually falls down, and then it allows the palatal shells to move towards each other and finally fuse with the surrounding structures also, and then form your secondary palate. So if you look at the histological section, that's how it looks like. You have two palatal shells initially growing vertically down because of the position of a vertically oriented tongue in between. It is only at the 7th week of intrauterine life that the tongue drops down and it allows the fusion of the palatal shells, thus leading to formation of your secondary palate. So if anything goes wrong over here, tongue does not move down, there is going to be a cleft in that region. So ideally 7th week, that's how the palate should look. 8th week intrauterine life, the palatal shells shall be much closer to each other. 9th week, they'll be almost fused, followed by calcification. What if things go wrong with palate formation? Then it can be to different extent depending upon which part failed to fuse with each other. So if the malfusion is limited to uvula, you'll have a cleft of uvula as seen in this picture. If it is involving the entire soft palate, then you will have a cleft of soft palate. If it involves the entire palate, then it can look like this, or it can be as disfiguring as involving the palate, lip, and even the base of the nose. Next, the baby is born and we are going to deal with the postnatal growth of the maxilla. So before we start, I will introduce you certain new terms related to growth, which include drift, displacement, remodeling, and relocation. So the basic terminologies are, whenever a bone is growing, there is bone deposition and bone resorption happening to the bone. Okay, so there'll be resorption on one side, that means the bone will get removed, and there is going to be deposition on the other side, and ultimately you will see that the bone grows or moves in the direction of bone deposition. So this can also be termed as remodeling. When you have continuous resorption and deposition happening, we also term it as remodeling. Now the remodeling purpose can be different, and hence we have different types of remodeling. You call it biochemical remodeling when the purpose of this bone deposition and resorption is merely to maintain the calcium phosphate mineral homeostasis, which keeps happening continuously in a human body. Growth remodeling is typical in the childhood when it is actively leading to increase in the bone size. So your deposition is very prominent. Haversian remodeling is when there is a natural change in the type of one type of bone to another type, and if there is any remodeling or deposition or resorption happening because of that, we call it Haversian remodeling. Regeneration and reconstruction will be an accelerated deposition happening, which is typical following any pathology or trauma. So it's a form of recovery. Now, the term drift, if you look at this particular construction site, you can try and appreciate this person is trying to remove the bone, the bricks on one side, and it gets deposited on the other. Okay, so the bricks is there, he removes it from there and adds it to the other side. So there is a change, there is a drift of the brick structure which is happening. If we try and apply it to the bones, we call it cortical drift. Remember, you have cortical or thick bones, cortices surrounding any bone, and the center part of the bone is comparatively less dense or spongy. Spongy bone surrounded by the cortices. So if this is a spongy bone and you have one layer of cortex, and suppose there is resorption of little of your spongy bone, in turn, to compensate for the shape, there is deposition on the other side. So here other side is the cortex. So little cortical bone has been increased. Then there is further deposition, resorption or removal of the spongy bone, and further addition of the cortical bone on the other side. And this way, this remodeling or bone deposition and resorption ultimately leads to the change or the drift of the entire spongy bone into the cortical bone. Hence, it is termed as cortical drift. The next terminology is relocation. So you look at this brick, concentrate on the yellow brick and see its position. It seems that its relative position is changing compared to the surrounding bricks. However, if you would have concentrated, the yellow brick itself is not moving in position. It is the growth of the surrounding structures which is making it relocate in relation to them. So this type of growth is called relocation, where the structure itself is not moving but appears to have moved or relocated due to growth in other surrounding structures. So a typical relocation is seen in relation to mental foramen. So if you see at the young mandible on top progressing to a mature mandible at the bottom, and look at the relative position of mental foramen, the mental foramen appears to have moved occlusally or away from the base of the mandible. However, it has not really moved by itself. It is just the apparent and the overall growth of the surrounding mandible which makes that the mental foramen has shifted in position. So this form of change in position is typically due to relocation. Then we move on to displacement. Displacement is basically movement of the whole bone as a unit. Okay, so that's called displacement. There are basically, it is actually involving your deposition and resorption, and as I've told you already, that in general, as there is deposition happening on one side and resorption on the other, there is displacement of the bone also happening because the bone is going to move in the direction of deposition. So displacement is being accompanied by your remodeling. So all these growth terminologies are actually interrelated. Now there is something which is called as primary displacement. That means that if you look at the condyle over here, the condyle has grown, there has been active deposition and resorption of this condyle, which has led to a change in position or displacement of the mandible. That means the bone's its own remodeling and deposition and resorption has led to its own change in position. So it's called primary displacement. However, a second situation is secondary displacement, where a bone is going to displace in position but not because of its own growth. It is going to be displaced due to a growth of some other adjacent attached bony structure, like growth at the middle cranial fossa. So you have deposition happening at this end. which is going to lead to bone deposition, and the entire maxilla which is attached to it is going to be pushed downward and forward because of the growth at middle cranial fossa. So this is a secondary displacement of maxilla happening due to a growth of an adjacent structure, not because of its own growth. So basically a remodeling is happening at every position. So when you're having primary displacement, that means a bone's its own remodeling, deposition and resorption happening will also obviously lead to a displacement or change in position of the bone towards the direction of deposition. Okay. And if we compare it with our maxilla again, so if it is the active growth of the maxilla itself, that means deposition happening of the maxilla itself, its own remodeling happening, then also the maxilla is being displaced downward and forward. So this is the primary displacement of maxilla along with its own remodeling. However, if it is the ball which is shifting, that means the movement of the ball, the growth of the ball which is leading to a shift in position of another structure, that is secondary displacement. So again, going back to maxilla, if it is the growth of the cranial base or the middle cranial fossa which is pushing the maxilla downward and forward and not the maxillary's own growth, then we call it secondary displacement of maxilla. So actually if you see, the growth of maxilla is due to both primary and secondary displacement. To be little more specific, the postnatal growth of maxilla in all three directions, let's have a look. That means in width, height and depth. So the growth in the width will occur due to displacement and drift. Earlier stages it is more of displacement, both types, and drift in the later stages. So if you look at the growth in width, it is predominantly because of deposition of bone at the sutures, various sutures. So you have metopic suture, internasal suture, you have intermaxillary suture, mid-palatine suture, and you have your symphysis, okay, from top to bottom. So if there is deposition of bone at any of these ends, it is going to lead to widening of the entire structure. Okay, now let's have a look at the surrounding sutures of the maxilla. So if you look at the direction of the attachment, that means the direction of the suture, deposition in that particular direction will lead to a change in growth or displacement of the bones in the same direction. For example, you have a temporozygomatic suture between the temple bone and the cheek or the zygomatic bone. Okay, so this is the direction of the suture. So if there is any deposition here, there is going to be an antero-posterior displacement of maxilla. So because of the growth at this end, deposition at this suture, the maxilla will be displaced forward and temple backward. Okay. Then moving on to growth and height, when we compare a fetal skull with an adult skull from the inferior border of the orbit and we compare the nasal height, you can see a drastic change there, and that's your mid face. Now it's actually attributed that there is a marked increase in the nasal size to ensure adequate airway. Now again, you can apply various growth theories which have given their own reasoning for the same. So it says cartilage theory versus functional matrix theory. According to cartilage theory, since your nose is primarily made of cartilages and cartilage is the main genetic, it forms the main source of growth, it has a growth potential, hence nose will grow more. However, functional matrix theory says that with adult size being achieved, you are utilizing your nose more for breathing, more function, and since the function and the space is going to grow in size, therefore the surrounding bony structures will also grow. So again, we still don't know which theory grows the best. Now we concentrate on drift in palate. So if you look at the palate, you have the nasal side and oral side. you have resorption on the nasal side and deposition happening at the oral side. So if that's the situation, the palate will be moving downwards with time. Okay, that means in the direction of deposition. So that's the natural growth which is happening postnatally. And if we concentrate and look at the remodeling, look at the shape in which it is happening. Not V, but you can definitely say it is a modified V. Okay, with the entire palate is moving down and widening, which goes according to your V principle of growth. So there is a change in position and change in size, both happening together, with palate becoming wider with age. Now if we concentrate on the palate again, remember there is again a thick bone. I told you a cortex will be there and inside less dense bone will be there. So now I'm going to divide your positive and negative signs a little more. I'm complicating it for you. So we all know that there is deposition happening below and resorption happening on top, right? To maintain the width of the cortical bone, you have to put the opposite signs on the inner side of the respective cortex. Okay, so if there is deposition here, there has to be resorption on the inner side of the cortex, and here if there is resorption on the outer side, there has to be positive sign or deposition inside, because the cortical bone cannot be completely replaced. To maintain the width of that particular cortex and make it look normal, this is the natural thing which will happen. Okay, so now onwards you're going to see two signs on either side of the cortical bone. If you're comfortable in making only one, you can do that as well. So that's your point A, which is the deepest point in the anterior contour between the ANS, anterior nasal spine, and the beginning of your maxilla, the alveolus. So that's called a point of reversal of your deposition and resorption, because above it you see a marked deposition of bone and below it you see the resorption of bone. That's your maxillary central incisor. Okay, so if you look at the nasal airway, it tends to widen, so there is resorption from inside. So I'm pushing the bone out. I told you with time the nasal cavity is going to enlarge. Of course we want a strong base, so on the top there is deposition, but rest everywhere there is expansion of the nasal airway, which can be attributed to either cartilage theory or functional matrix theory. And below, I already told you the palate, how is it going? It is moving down, deposition downwards and moving down. So we already know that is in accordance to your V principle. Yes. So that's how all the structures are growing, the nose and palate. And let's see what's happening with the maxillary sinuses now. So the entire structure is been growing. The maxillary sinus is also going to widen, just like your nose, because of your functional matrix theory. The entire space is increasing. The functional space is increasing in size. Okay. Now to counteract the expanding nose, to form a wall interiorly, the maxillary sinus is going to wall off the nasal cavity from entering itself. Hence you see deposition on the inner side. Rest everywhere there is going to be lateral expansion of the maxillary sinus as well. Okay, so as you see, the maxillary sinus is expanding and approaching the orbit. Similar way, the orbit will also try to form a barrier, inner defense wall, so that the maxillary sinus does not invade itself, and hence you will see the bone deposition on the inferior part of the orbit. Laterally you will see expansion of the orbit as well, so you will see typical negative signs. So the orbit is expanding laterally, and outside, to keep the bone width, there is going to be deposition. On the medial surface of the orbit, you have mixed signs, because the wall wants to expand, but it has to form a barrier inside, making sure that the expanding nose does not invade. So you have mixed signs of deposition and resorption happening. Now, if we look at the maxilla, we cannot ignore the most posterior part of the maxilla, which is present posterior to the posterior most erupted tooth. That's your maxillary tuberosity, which contributes to the growth of maxilla in all the three directions: posteriorly by bone deposition, even laterally, which leads to an increase in arch width, and also downward inferiorly, which leads to an increase in alveolar ridge height. So it is actually contributing to the growth of maxilla in all the three planes. Maxillary tuberosity is a very important growth site. So we move on to the applied aspects. So if you look at this particular tribe, they were traditionally known to wear this lip plate in the mandible, and it was supposed to be very aesthetic. And with time, since they were continuously trying to alter the function by putting that plate or ornament there, their lip and the lower mandible actually grows out like that. That means even if they remove the plate, the lip looks like that, it grows like that, it changes with time. So this goes in accordance with your functional matrix theory. So I'm just trying to show you that how, without even realizing, we have utilized this functional matrix theory in various tribes. It's just been there in our culture. So if you look at this particular tribe, it was believed in their tribe that only the people who have a flat skull can be considered to be kings. So if you want your child to become a king in the future, he must have a flat skull. It's a superstition, but see how they have actually done that. So when the child was growing, they used to suspend the child, make the child sleep in this position with a harsh thing over there, and they are forcing the child's head, applying pressure, making sure in that growing age itself the growth of the skull is restricted from top and it becomes flat. So you're actually applying active pressure, orthopedic force, and inhibiting the growth in a particular direction and leading to flattening of the skull, just to claim that you can become a king. And they actually did that. So another example, it was considered that long necks are very aesthetic for females. So they used to wear these brass ornaments in their neck right from childhood. So it actually grew their necks really long. So that means you can grow the structures if you want, you can restrict any of the structures growth if you want. It has been happening. So we're not going to do anything new. Actually, we are late, right? And you have the Chinese foot binding principle. So since small feet are also a sign of aesthetics, especially for females, so it was believed that if they wear smaller size shoe and they bind the growth, that means they inhibit the growth of the foot. They do not let the feet attain its full growth in length. So they make it smaller in size, and they were considered to be more aesthetic. So that means you can they are restraining the growth of the foot. So this principle of restraining or trying to grow any structure is not just applicable to the oral cavity or the face. It's actually been used previously till the feet. Imagine. So that gave us a clue, and then we realized what we can do as orthodontist and dentofacial orthopedics. Orthopedics means modulating the jaw growth. So if you have a female who comes to you like that with a maxilla which looks very prominent, and also vertically you see lot of gumminess is there, that means vertical growth of maxilla is too much, and even antero-posteriorly maxilla is too much in front compared to mandible. Since she is growing, what we can do is, if we want to make her look normal and good like this, that means we have to restrain the growth of maxilla. In upward, we need to pull the maxilla up and behind by giving her an orthopedic appliance which is called a headgear. So we are pulling the maxilla up and behind, taking support from the forehead. So these are your growth modulation procedures. Hence, at what age which jaw can be manipulated or modulated and in which direction. For that, we need to know the ideal timing of growth happening, and hence growth of maxilla and growth of mandible is something you have to master as an orthodontist. Thank you everybody. If there are any queries, please feel free to question me. It'll be a pleasure for me to answer. Thank you.